So hello, everybody. My name is François Bochud, and I was one of the co-chair of the task group that prepared this publication 157, Ethics in Radiological Protection for Patients and Diagnostic and Treatment. And I'm really happy to realize that there are a lot of people. I've heard that you are at least 200 right now, but I think it's maybe more due to the people who registered. So you received the program, and I'm just doing the introduction just to make sure that you have a broad view of what is in this publication. So first of all, I would like to start by having some thought about Marie-Claire Canton, who was co-chair of this task group with me, and very unfortunately she passed away at the end of last year, and she really contributed significantly to this report, and we will really miss her, that's for sure. So who was in this task group? So here you have all the list of the members who were in this task group. Obviously, we had some people who were expert in ethics, but we also had medical doctors, a lot of physicists, like I, maybe too many physicists, I don't know, and one artist, which is, I think, a good representation of people involved in this field. What was the mandate of this task group? Well, you probably know that ICRP had a publication on ethics in general, in publication 138. And actually, we were asked in this present task group to develop a publication that is more dedicated in use of radiation in medicine, but not something just vague, but quite practical. And we wanted to make sure that we started by making the link with what was already existing in medicine, because medicine has a long history on ethics. So we have to take into account what is already present in medicine. But our task group also thought that we could bring something, and this something was the specificities of radiological protection, and try to make the link between our field and biomedical ethics that is already present. So just to simplify and give an image of what was our mission, was essentially to make a bridge between the RP community and the medical community. So here you will have a kind of animation of the table of content of the report. So after the introduction and goal, we had a chapter in which we explain what is ethics in radiological protection, and also what is ethics in biomedicine. And Friedo Zölzer will tell more about this. I will just have a few things to say. As I said, in biomedical ethics, they already had a lot of ethics intrinsically since a very long time. And here you have the four principles of ethics that are present in biomedical ethics, but they also have some other principles that are becoming more and more important with time. And on our side, on the radiological protection side, we don't have principles in ethics. It's because the word principle was already used for justification, optimization, and limitation. Therefore, we call them not ethical principle, but we call them core values or values. So, and these values are quite similar. You can see beneficence, non-maleficence, justice. Then we had something slightly different: dignity, prudence, and in the ICRP report on ethics, we also had inclusiveness, accountability, and transparency. So one of the first things we had to do was to do some cleaning between those different values. And for instance, it was quite easy to put together the first one because they are exactly the same. We thought that justice and solidarity could come together also. You'll see why afterward. Autonomy and dignity are really close to another. So therefore, we decided also to pair them. And prudence and precaution also are quite similar. Inclusiveness and empathy also, and the last ones also clearly. It was not difficult to see why they should be put together. So again, Friedo Zölzer will tell you more about this later. Then we had another chapter, practical development in biomedical ethics, to see what happened recently, what are the link with the code of ethics, the professional oath, so quite a lot of things that Chieko, Kurihara-Saio will tell you more in a moment. And then in chapter 4, we thought that it would be really good to make sure, if we really want to bridge the RP community and the medical community, it would be good to see how each community can talk to the other. And I have a few slides to show you this. So we put ourselves in the shoes of people who know more about ethics, and we ask ourselves, what could we teach for this kind of people from a radiological protection point of view? And typically, this is what we had to tell them. We wanted to explain what is the stochastic effect, tissue reaction, all this in the framework of ethics, obviously. There are some particular factors that affect radiation sensitivity, age and sex, individual sensitivity. And there is also this whole part about uncertainty that we know when we are specialists in radiological protection, but we don't know when we are ethicians or people familiar with ethics, and which could be good to know if we want to do our job in the best way possible. From the other side, we put ourselves into the shoes of people who know more about radiological protection, and we ask ourselves, well, what could people specialists in ethics could teach us, who are specialists in radiation protection? And typically, this is what we had to say. There are some special aspects in medical use of radiation. In particular, it's a deliberate exposure. People who receive the dose, they do it with consent most of the time. It's voluntary, at least. The demography is not the same as the usual population. We also wanted to make the link with the principle, what we call principle in radiation protection, justification, optimization, and also well, limitation is not clear. Okay, so that's what is in chapter 4. In chapter 5, we become more practical. Lynette Reid will tell you more about the fact that we propose a set of questions that we should ask when we have a problem that has some ethical aspects in it, and Lynette will show you how we can actually have a question that makes the link between a specific case and the principle or the values of ethics. And then Jim Malone, who will unfortunately be absent, but he recorded his presentation, will present you a practical method that we developed and actually that we propose in this publication on how we can actually assess a specific situation with the ethical principles. And in order to be really practical, we also have 2 other chapters in which we apply the method. There are cases in diagnostic, there are cases in therapy, and Jim Malone will tell you about some of them, and Mary Coffey will tell you about the cases of therapy. So just to make sure you have a broad view on this, we tried, at least at the beginning, we wanted to put everything on one page. Everything was prepared to be on one page, but for editorial reason at the end, unfortunately, we were not able to have them on one page. But anyway, it's short. That's what is important. And on this so-called one page, we have every time the description of a scenario. Then we have a table of compliance in which we try to analyze the scenario and see if we are complying or not according to ethical principles. And then in the third part, we have a proposed analysis of the scenario that justifies the content on the table, why we think we are complying with an ethical principle or not. And we have quite a lot of examples, 11 in imaging and 10 in therapy, and some examples will be given afterward, as I just said. If you want to have an idea of the subject that we treated in the document, you can see and have some broad idea here. Okay, and then at the end, I think it's always important to make sure that the people in the field can actually apply what is proposed in the ICRP recommendation, especially for a subject like this. And Kimberly Applegate will tell you more about education and training, how we could make sure that people who need these competences actually get them. And for this, we tried to be as modern as possible from a pedagogical point of view. So you know that there are different levels of competence. Start with remembering, understanding, applying, analyzing. So, okay, you know this kind of thing. So there are different levels, knowledge, skills, competence. Kimberly will tell you more about this, but I just wanted to show you a very, very simple example of these 3 levels. For instance, for the knowledge level, just to be able to identify the core component of dignity and autonomy. So it's just a very basic skill level. At the middle level, for instance, aware of the fundamental human rights that dignity and autonomy and privacy must be respected. And at the highest level of competence, be able to support the patient in making a decision. So you see this kind of competences. Not everybody needs to have all of them, but at least we have a proposition of curriculum that is quite complete. Okay, so in summary, we hope that the report will help the medical and radiological protection professionals to interact together. This report proposed practical methods. For us, it was really important to have something that is really practical. You will see, we are really our feet on the ground with an approach that can be practically used by almost everybody. Anyway, even if it's practical, the theoretical part is quite important, and we also have all this component in the report. And we really think, and that's the recommendation of the ICRP, that education and training in ethics should be really a priority to work in medicine. And in order to make sure that this subject that could sometimes be complicated, or at least complex, we innovated in the report in the way that we put key messages all around the report. I don't remember how many we have, but I think it's 41, something like this. The key messages that are really identified in the text, and you can just read the key messages. And if you want to know more, you have the details and the explanation that are very close to where the key messages are. Okay, so as I said, the person who will speak after me will be Friedo Zölzer. Maybe just one organizational point of view. You most likely saw that in the system. I will stop sharing my slides. In the system, on the bottom, you have a Q&R button. So if you have questions, please use the Q&R button, and the members of the task group will be happy to try to answer your question directly during the meeting, or at the end. Hopefully, we'll have some time for the question who will still be there. We will be able maybe to give an answer orally if it's necessary. Anyway, at the end, we will keep all the questions and answers, and we will answer those that have not been answered during the meeting. They will be answered afterward and then put on our website. So thank you for your attention. And now, Friedo, I give you the floor so you can share your screen.
Yeah, thank you, François, for this very clear introduction. And thank you for already addressing some points that I should address. But of course, I tried to do it in a bit more detail, although we all have only 15 minutes to speak. So without further ado, I will try to share my slides. And I will speak about Chapter 2 of our report, which is some basics about ethics in radiological protection. So the first part of the chapter discusses the background, ethics in radiological protection. And the second part is about interpretation of ethical values in radiological protection and in biomedical ethics. So how do the interpretations from both sides fit with each other? François has mentioned that the most important basis for our discussions, for our report, is the ICRP publication 138, which appeared in the year 2018. It is not the very first ICRP publication that ever addressed ethical questions. There was, for instance, one about environmental aspects of radiological protection, where environmental ethics was discussed to some extent. But it is the first publication of the ICRP that is dedicated exclusively to ethics, and it focuses on the ethical foundations of the system of radiological protection. It was supposed to consolidate the basis of the recommendations of the Commission to improve our understanding of the system. So what are the ethical underpinnings of the system of radiological protection? And also it was supposed to provide a basis for better communication on radiation risks and risk and its perception. The task group that put together publication 138 was supposed to find a minimum set of values, or not a long list of values, but just a few values that would be really important, that would be relevant to the system of radiological protection, of course, and that would stand the test of being applied to current and foreseeable problems with sensible results. So they should be applicable, and they should be relevant to the current problems of radiological protection, and they should give sensible results in the sense that people would say, yeah, that makes sense, that is reasonable. It's not going off into philosophy too much, but it is down to earth and applicable. And also, what was very important for this report was that the values that we would identify would be common, or at least acceptable, in the widest possible range of cultures, because we are having an international endeavor here, the International Commission of Radiological Protection. And if we base everything just on European, or let's say Western concepts of ethics, that may not be what we really need and what we can work with, but we have to make sure that it is also acceptable in the Middle East, or in India, or in China, or in Japan. And we did try a lot to make sure that this is the case. François has already mentioned the core ethical values. I said a limited number. So here we call it four. We called it four, although the first one is already a combination of two: beneficence and non-maleficence. So beneficence is promoting or doing good. Non-maleficence is avoid harm. Then prudence was defined as making informed and carefully considered choices when full knowledge of the scope and consequences of something is not there. So you have to make certain assumptions about the action of radiation at small doses, for instance, and you do that in a prudent way. So you take into account that there may be some effects, but on the other hand, you also stay reasonable, as low as reasonably achievable with the doses. You stay reasonable because you don't want to overdo it and spend money and resources on risks that are probably not there. So it is also a weighing of things. It's a weighing of being precautious but not over precautious. The third value is justice. Here it is mostly, not only, but mostly about the fairness in the distribution of advantages and disadvantages, so that not certain people have the advantages and certain other people have the disadvantages, for instance. So it's about fairness. And the fourth value that was identified was dignity, the unconditional respect for every person, that every person deserves, irrespective of personal attributes or circumstances. Now it doesn't want to. The task group also suggested, and the Commission accepted this suggestion, that there could be some procedural values. So these are values that are most important for the application of the core values. The core is the core, the nucleus, the basis, but these three are more for the practical application, for the procedures in radiological protection. And the three that were identified here were accountability, transparency, and inclusivity. Where accountability, of course, is the obligation of individuals and organizations to answer for their actions. Transparency is the accessibility of information about the deliberations and decisions concerning potential and ongoing activities, and the honesty with which this information is transmitted. And inclusivity, there's also in brackets the term stakeholder involvement, ensuring that all those concerned are given the opportunity to participate in discussions, deliberations, and decision-making. So that's the summary of ICRP 138. And now, of course, we realized, and François mentioned this, that we have a very similar system of ethics in what Beecham and Childress published first in 1979 as the Principles of Biomedical Ethics. Now, François also said we don't, in radiological protection, we don't speak about principles with the ethics, because we have used the word principles already for the principles of justification, optimization, and dose limitation. So here we speak about values. In biomedical ethics, they do speak about principles, but here are, I also called it values here, not to confuse too much. And these are the four that Beecham and Childress suggested. They said that if we look at these principles, we can solve almost every conflictive situation in clinical medicine by looking at these four principles. Sometimes we will see that not all four of them can apply at the same time. Sometimes we have to balance them. So balancing in this respect means that we try to find out whether in this particular clinical situation, one of them takes over, one of them is more important than the others. Sometimes we can apply all four of them without a conflict, but sometimes we have to make choices. And that's a great part of the discussion in Beecham and Childress's book. How do we do that? How do we, in the particular clinical situation, find out what is more important, what is maybe less important in this particular case. Now you see that there is a very great similarity between the left and the right side, but the order is not quite the same. So the ICRP shifted dignity, had dignity as a fourth value, but respect for autonomy was the first one that was mentioned by Beecham and Childress in the Principles of Biomedical Ethics. So in the report 157, the decision was made that we would follow the order that medical people in the medical field are used to. So we shifted dignity to the front, and otherwise the order was kept. Yeah, so here is dignity, and this is similar, I'll tell you a few more things later, to respect for autonomy. Then we have beneficence and non-maleficence, which Beecham and Childress mention as two separate values, but we put them together here. Prudence is in the system of radiological protection, but not mentioned or very briefly mentioned in biomedical ethics. And justice, of course, is there in both systems. Now, what the task group for preparing 157 did was trying to add to the core values and the procedural values from ICRP 138 some additional values that would make it clearer how these core values and procedural values are applied in the medical field. And mainly there are additional interpretations or of the core values. Sometimes you would say, well, maybe this is not an interpretation, that it's a correlated value, but most of them are actually, yes, interpretations of the core values. For instance, dignity is, I think I have it, I said it before, dignity is something that every human being has without just by birth. And autonomy is something that follows from that. It is the capacity of individuals or groups to act freely, decide for themselves, and pursue a course of action in their life. So dignity is the more fundamental concept, and autonomy is a more applied concept, especially for the context of medicine. With beneficence and non-maleficence, it was decided that we would, as an additional interpretation, mention here the need for balancing. Now, I said before that all these values have to be balanced. That is, we always have to see if there is conflict between the individual values and whether we can identify one or two values that are more important than the others. So balancing is anyway in the system, but of course it plays a particularly important role here in the case of beneficence and non-maleficence. You want to do good, but you also want to avoid harm, but sometimes you have to inflict some harm in order to do good. And that is particularly relevant or visible, for instance, in radiotherapy, where, of course, you want to do good to the patient and eradicate the tumor, and you don't want to harm the patient, but you have to harm the patient to some extent. You have to go through healthy tissue, for instance, with your radiation in order to reach the tumor. So you have some harmful effects, which cannot be completely avoided, but you have to do good balancing. You have to make the benefit as great as possible without having the risks too significantly. Now, I said this, I think, so I skipped this slide. With prudence, we thought that it would be good to mention precaution. I said before that prudence actually is a combination already of being cautious, being looking at possible effects that we don't know exactly, but we assume they might be there. And on the other hand, not overdoing it, but being prudent and being reasonable and taking into account economic and societal factors, not to waste money and not to waste resources. But a very important aspect of this is precaution. And we thought it would be good to mention this because the concept of precaution is certainly also known in medicine. So here is a definition, if you want, or a wording. Precaution is about measures taken to prevent and reduce risk in the absence of scientific certainty. And the other aspect, I may add again, of prudence is not overdoing it and staying reasonable. Now, justice is fairness, as we said before, but also solidarity plays a role here. So we want to be we show solidarity with people, especially underprivileged people in society, people that are not as well off as others. So consideration of the common good and the societal structures that ensure it, as well as interpersonal relationships of recognition, reciprocity, and support.
You're just for 15 minutes.
Yes, I know. I should finish, and I will shortly. Just to say that we also paired further values, or we had additional interpretations for the procedural values with accountability and transparency. We emphasized honesty, although it is part of the definition of transparency, but maybe, again, a term more widely used in medicine. Honesty and with exclusiveness, we paired empathy because you have to put yourself into the shoes of your patients, sharing another's emotional response and or understanding their feelings and perspectives helps you to include them in the decision making, and therefore it is something that belongs to inclusivity or stakeholder involvement. And that's the setup that the group came up with, and a few more details of how this balancing is done and how the additional interpretations are applied will now be shared with you by Chieko, I think. Thank you.
So thank you, Friedo, for your nice presentation. I will go to the next part. I'm sorry. So thank you very much. So my name is Chieko Kurihara. I will speak about the chapter 3 of this report. In chapter 3, we discuss about the practical implementation of biomedical ethics. We will learn key developments in clinical practice that implement the core and procedural ethical values. So this is the contents of chapter 3. In providing patient care, we often face questions not just about technical skills and scientific knowledge, but also about values, human rights, and responsibilities. This chapter focuses how we can implement core and procedural values clarified by ICRP should be considered in the actual clinical practices. Points of discussions are listed here. So first, we will discuss about the professional oath and codes of ethics. Historically, biomedical ethics was expressed in physician oath. World Medical Association's Declaration of Geneva was adopted in 1948 and last amended in 2017. It provides a modern perspective to the ancient Greek Hippocratic Oath, emphasizing humanitarian aspects of medicine. The Geneva Declaration describes the physician's pledge, including respect for the individual patient, as well as doctors' own health and well-being, in order to provide care of the highest standard. The WMA has also issued a series of ethical and social policy documents on various topics, for example, patients' rights, patient safety, end-of-life care. ICRP issued in 2014 their Code of Ethics. Some other professional societies related to radiological protection have issued their own Code of Ethics. So you should consult with those of the societies you are engaged in. Next, we will discuss about the role of ethics committee. There are many types of committees of the level of international, national, or institutional. International ethics committees have been established by professional bodies such as the World Medical Association, Council of Europe, UNESCO, as well as WHO. Their role is to provide bioethics policy formulated as international agreement. UNESCO recommends establishing national and institutional ethics committees in its Universal Declaration on Bioethics and Human Rights issued in 2005. National ethics committees advise government, national bodies or institutions, and inform the general public, providing national policy on newly arising ethical issues. And the role of institutional ethics committees is more directly related to ethical dilemma you face in everyday's or ordinary practice. Healthcare facilities may have clinical ethics committees or ethicists, sometimes called ethics consultants, who formally consult on ethical dilemmas. Ethics committees are independent, interdisciplinary teams that provide education, policy development, and case consultations. Ethicists or ethics consultants will provide consultation for each case, and sometimes they request for discussion in ethics committee. In case ethical issues concerning use of radiation arise, radiological protection experts may be requested to participate in such consultation on an ad hoc basis. If such issues are common, ICRP recommends that radiological protection experts should be included as a member of the committee. So next we will discuss about the clinical practice development, considering the topics of informed consent, privacy protection, end-of-life care, professionalism and financial influences, and radiological safety culture. All these practices will be implemented, integrating and balancing ethical values, which ICRP clarifies in this and the previous reports. So first about informed consent. Legally, the requirement of respect for autonomy, derived from respect for dignity, has been specified in the requirement to seek and respect patients' informed consent or decline of medical interventions. Patients have to be informed of the risks and benefits of a proposed treatment or diagnostic intervention and its alternatives, including doing nothing. Patients are free to make a decision without coercion. Recently, shared decision-making model in patient-centered care, patients are asked their preferences and clinicians actively facilitate a two-way exchange of information. Shared decision-making for diagnostic and therapeutic procedures is often a key element in radiological protection in the clinical context. There is growing awareness toward improving transparency by communication and education about risks and benefits of the intervention. It should be noted that the Image Wisely and Image Gently campaigns provide materials to assist in communication of risks and benefit. Practical approaches to respect for autonomy in the situation where patients lack the capacity for consent have been defined by laws in many countries. Healthcare professionals must be aware of their local regulations and cultural context. They should also be aware of the evidence that even hospitalized patients with psychiatric conditions often retain capacity for medical decision-making. For a pregnant woman or a woman of childbearing age, full information of risks of high-dose diagnostic procedures or radiation therapy should be provided. It means the information on the risks to the fetus, the possible effect on the continued pregnancy, and the long-term well-being of the child, as well as the effect on childbearing capacity. It should be noted that fetal doses below 100 mg should not be considered a reason for terminating pregnancy. The question of involving the pregnant person's partner or the father of the fetus in decision-making can be a sensitive issue, especially in the context where women's rights are not well respected. In any case, shared decision-making with the family and the medical team, including radiation experts, is particularly important. The developing capacity of children is recognized in the process of seeking their assent, which means agreement of receiving interventions based on understanding of the risks and the benefit according to their capacity of understanding. The extent of the parent involvement in consent for pediatric patients depends on the age and the maturity of the patient. You should be careful because the manner and the scope may differ in different jurisdictions. Next, patient privacy and confidentiality are expression of respect for human dignity and autonomy and have a long history in biomedical ethics. The general physical layout of the imaging or radiotherapy should ensure the patient's bodily privacy. Recently, expanding use of artificial intelligence and machine learning leads to standardization and optimization of imaging. As technology and research practice evolve, we should more consider about privacy protection in the settings of using large amount of personal information. At the end of life care, reducing stochastic effects of radiation becomes less important. At the same time, imaging that is painful and disruptive for very ill and dying patients should be avoided when it will not benefit the patient. The values of non-maleficence and prudence should be considered in these cases. Advanced Care Planning, ACP, has recently been formalized in various regions as a process where patients can develop an explicit plan considering a future where they come to be incapable of expressing their own will. In radiological protection, conflict of interest may include physician ownership of diagnostic and treatment equipment or personal benefit from referral relationships. In radiation therapy, the increased financial benefit can result in patients having an extended course of treatment. The common ethical goal is to ensure that clinical decisions are made in the best interest of the patient and not for the financial gain of health professionals or institutions. As a conclusion of this chapter, we mention the important concept, radiological safety culture. Radiation safety culture is harmonious with the broader concept of patient safety. It can be understood as a combination of habits and knowledge of radiological protection in all its aspects for workers, patients, population, and the environment, and in all exposure situations, combining scientific and social dimensions. Culture is the product of individual and group beliefs, values, attitudes, perceptions, competencies, and patterns of behavior that determine the organization's commitment to quality and patient care. Because ethics is therefore clearly a part of radiological safety culture, appropriate education and training in ethical values is extremely important. Thank you very much for your attention.
Thank you, Chieko. The next person is Lynette Reid. Lynette, you have the floor.
Okay, so thank you, Friedo, for the review of the core and procedural values and their definitions and their clinical interpretations. These core and procedural values are key ethical concepts that have important application in radiation protection and in clinical practice of healthcare providers who work in this field. They're highly abstract, and they require what we call in bioethics interpretation and specification before you can use them in thinking about ethical situations that arrive in your own workplace and in patient care. These are technical words for the process of understanding which of several possible interpretations. Justice is a word, for example, that has many different interpretations that are all very important in biomedical field and in health policy. So understanding which of several possible interpretations of a value term is being considered or discussed by the medical team in the case in question. And for specifying, so that was what Chieko has brought to the discussion. Chieko has talked about how all these different values in biomedical ethics are now being specified or actually carried out procedurally, operationalized in clinical practice. So to take an example, if we look at autonomy, that value can be specified, can be interpreted in the medical field in the context of the practice of medicine through the value of informed consent, that we respect and seek patients' informed consents for medical procedures. So that involves the requirement that professionals provide information and opportunities for reflection. And there are then specific procedures, and that's the operationalization of the value of autonomy through the specification and the interpretation of informed consent. And that specification includes specific procedures, as Chieko discussed, for how do you operationalize it when the patient lacks capacity, temporarily or permanently in an emergency context, at end-of-life care, and with children, for example. So each of these values being highly abstract, there's a lot of background knowledge and a lot of contextual understanding that you bring to the application of these values in the procedure that now Jim, after me, is going to talk about. So the procedure of how you actually analyze ethically dilemmas that you encounter in your workplace. So how does the report help you interpret these highly abstract values? You've already seen the context of past reports and analysis of the ICRP, which connects to your workplace considerations of radiological protection, and Friedo has presented that. You've seen the developments in clinical practice and the chapter that covers that Chieko has presented, that helps you understand how these very abstract ethical terms are used in practice. Friedo also presented the formal definitions, which are always an important touchstone, so you can come back to the formal definitions in discussions with your colleagues of ethical dilemmas. And what Jim is going to present next is opportunities to practice the application of these values. Now, in between all this and mediating all this is a table of sensitizing questions, and that's section 5.2. So that table of sensitizing questions is helpful for you as you work through ethical dilemmas, either the ones in the workbook, the ones in the report that you can practice with, or ones in your own clinical setting. Often, people have a sense or a perception of an ethical dilemma or an ethical concern in their workplace through a feeling more than through an intellectual process. Sometimes the words and the principles or the values and the intellectual content that describes why there's a concern in the current situation, sometimes that comes first. But very often what comes first for people is a feeling of discomfort, conflict between different people, so conflict in a group, or even a general feeling of perhaps guilt or shame that if what was going on right now was known widely, maybe it would be judged, or maybe it would be considered inappropriate. So those kinds of strong feelings are sometimes how we first realize that there's an ethical dilemma that is happening. And those strong feelings are important because ethics comes to us in terms of strong feelings, in part because it's so internalized. Ethical values govern how we interact with other human beings in our lives, with strangers we encounter on the street, with our closest personal friends and family, and we often share ethical assumptions, core ethical assumptions. Ethics wouldn't play the role it did in our lives if we didn't share those core values. But we don't always share those core values. We don't always share interpretations of them, and we don't always share specifications of them. But the closer people are to us, the more we tend to share them. So there's a sense of harmony and ease in our relationships when we're in situations that don't challenge, where we all agree with one another. But when there's uncertainty and when there's conflict and when there's sharing, we suddenly have to bring to words things that we might not be very experienced with putting words on or discussing. And they go to our identity. So we might feel very personally that a lot is at stake, and very personally We might find ourselves judging our colleagues negatively, for example, because of the importance of ethical values and how we relate with one another. So when we're in that situation, we have all those feelings about a scenario at work, it's very important to start to bring words to it so we can share perspectives and we can discuss and weigh what our options are for acting, and we can look for ways that respect as many ethical values as much as possible, and violate as few as possible and as little as possible. So I'm going to suggest that I'm going to show you how you can use the sensitizing questions. They're just questions that help you link the abstract principles with the actual developments in clinical practice that Chieko has talked about. And in order for us to go through this, I'll just read some of the sensitizing questions. The table of sensitizing questions in section 5.2 is not meant to be exhaustive. It's not meant to be a complete set of questions. They're just prompts to get you thinking. So you might have a scenario in your professional life. I'll ask you to bring to mind, recall something that's gone on for you professionally, or even in your life as a patient or a family member that you just weren't comfortable with. You weren't sure whether the right thing was being done or whether things could have been done better. Bring that scenario to mind, and then you just see, you look through the list of sensitizing questions and you see if any of these questions help you connect that feeling of discomfort you have with specific professional obligations and specific ethical values. So they can assist you in the interpretation and operationalization of the core and procedural values. And that's how we designed Chapter 5.2. That's why we put it in. I found in teaching the materials in the report in the medical physics program, where I teach some ethics content here at Dalhousie, that they can also help you to check your own perspectives, to broaden your reflection on a case. So sometimes when you see a case, you see it completely from the radiation technologist's perspective. Sometimes you might see it completely from the patient's perspective. Sometimes you might see it completely from the treating physician's perspective. So these sensitizing questions can also help you see scenarios from different perspectives. They're not intended to be exhaustive. So take that scenario you have in mind, some experience from your old life, and ask yourself, have we provided, this might not apply, it might apply. You're just listening to see if these questions apply. Have we provided privacy for imaging procedures? Have we provided privacy for communication of test results, diagnosis, prognosis? Have we given people the space and time to do that without strangers observing them, for example? Have we shared patient information only for the purposes for which it was gathered? Do we know the patient's goals of care? And does the proposed procedure meet these? These are all very different questions about very different areas, but in the abstract set of values we've given you, they all fit under dignity and autonomy. Harm and benefit. Do the benefits of testing outweigh the potential harms? That's a question medical professionals are constantly asking themselves. Have the potential harms been minimized without loss of therapeutic efficacy or diagnostic accuracy? Is the procedure consistent with guidelines? Sometimes that's a clue to the question that there are important harm and benefit issues to be weighed. Are there specific considerations for this patient that aren't anticipated in the guidelines? And how do we bring those considerations to bear in this situation? Prudence and precaution. It's very important sometimes in evidence-driven professions to step back and say, have we thought about everything important we need to think about in this scenario, even if we don't have good evidence for it? Sometimes very important considerations lie very low on the hierarchy of evidence, and we still have to be responsive to them. Have we considered multiple dimensions, all the dimensions of the decision that we're making, or have we focused just on our piece, which we might sometimes do for very good reasons? Our own area of professional competency, our scope of practices is one piece, but to bring a decision that's good for the patient, we have to consider all aspects. Justice, there are so many justice questions that can be specified and interpreted out of that value. Are there social determinants of health that create barriers to care for this patient? Can we address these and improve access? Are we allocating scarce resources according to well-reasoned principles? Do we have fair processes for applying those principles? Are we taking steps to minimize the power imbalance between healthcare providers and patients or families? Are we using language they understand? Are we sitting eye to eye with them instead of speaking to them and asking for decisions when they're unclothed and lying, for example, if we can avoid that. Is this, and that's a whole different areas under justice and tech under justice. Is this new technology sustainable for the healthcare system? Some examples for accountability and transparency. Have we been candid with the patient about all treatment options, even those outside our own scope of practice? Have we offered the referrals patients need to gather decisions, information for their decision making? Are we delaying challenging conversations because we're uncomfortable with them? Are we transparent about potential financial conflicts of interest? So again, very many different specific issues that Chieko discusses in that Chieko has laid out from that chapter come under the interpretation of these core values. And these are the procedural values. So inclusiveness and empathy. Have patients been included in discussions of the options, or have we had those discussions behind closed doors? Have we taken steps to actually understand their concerns and perspectives? So inclusiveness doesn't just mean having people in the room, but actually trying to understand where they're coming from. Have we expressed that empathy and that understanding in concrete ways? Are we aware of our own limitations in engaging with other viewpoints and perspectives? Have we listened to those patient concerns without judgment? So this is how the table of sensitizing questions makes a link between the previous two chapters and the radiation and the background information in radiation practice that's important for interpreting these values in this context, and the method of analysis of clinical scenarios that Jim is going to present next.
Thank you, Lynette. And as you said, Jim is going to present, but he was not able to be present. And we are sure that he will take the 20 minutes on the schedule because it's pre-registered. So thank you again, Lynette, and we give the floor to Jim.
Greetings, colleagues from Dublin and Ireland. It's a pleasure to talk about applying the values that Friedo and Chieko have introduced. We look at examples from medical imaging in clinical situations. They draw on experience, but they're not literally true. Their purpose is not to demonstrate good practice, and that's important. It's to construct plausible, dramatic scenarios to illustrate compliance and non-compliance with ethics values. The idea is to provide an approach that can be used by those not experienced with making formal ethics judgments. The scenarios are simplified to render it easier to make such judgments. ICRP 157 also provides a novel tool for this, that is, a table of sensitizing questions that has been presented in Lynette's talk. So what do we talk about here in this talk? Well, principally, we'll talk for a while about the values, and principally the ICRP approach to the values, because there are many other approaches to medical ethics values. And the issue we'll be dealing with is the application of the values in medical radiation protection, and to look at a methodology for ethics evaluation when ethics is applied in medical radiation protection. We do this by constructing scenarios or stories about incidents or events that are worrying. We apply the values one by one to each part of the situation described in the incident. And we'll then have a few concluding observations on using the ethics approach as a lens for making judgments in this area. So to return to the values, which were already well developed by Friedo, there's a set of 6 value pairs. And I'll just go through them briefly. The first 4 of the 6 are relatively well known in medicine and in research indeed. The final 2 aren't as well known, and this particular approach is very much ICRP's approach. It's not necessarily the approach taken in medical ethics. But when we look at each of the 6, in dignity and autonomy, we're not good in radiation protection and need to spend a lot of time developing it for our discipline. With regard to beneficence and non-maleficence, that's do no harm and do good. We're relatively good. With regard to prudence and precaution, we're not really very good. The LNT is an example of where prudence is essential. With justice and solidarity, we're 50-50, I would say. We're good at an equitable distribution of risk, but not so good on resources or other areas. With transparency and accountability, we're familiar with it from public life, but we don't use it explicitly in radiation protection. And finally, with inclusiveness and empathy, there is a situation where we're not really very we haven't really advanced very far into those two values. Values that are commonly used in medicine and often use a different vocabulary. I'll give a few examples here because we have to be able to relate to these. Equity is used a lot in the development of medical services. We have a good surrogate for it in justice and solidarity. Privacy is used very commonly in medicine. We don't have any explicit reference to that, but it can be dealt with under dignity and autonomy. Transparency and accountability, we have then pair number 5, a good example. And confidentiality, we don't have any parallel in that's explicitly identifiable, but it would arise under dignity and autonomy, and it would also arise under inclusiveness and empathy, and possibly in other ways. The scoring system that we've adopted relies on developing a scenario, and we'll come to that in a moment. But we evaluate the scenario or the story using a table, and there are 3 rows in the table. The first row just sets out the 6 value pairs. So we go from the dignity and autonomy on the left, beneficence and non-maleficence, right through to inclusiveness and empathy as the 6th column. And we make judgments under 2 headings, under compliance and under non-compliance. Now, you might think this is redundant, that if it's compliant, it can't be non-compliant, but that isn't the case with ethical judgments of situations that are borderline real. Things can be both compliant and non-compliant within the same scenario. We represent our judgment in a scale that's represented by smileys, as we see here, or by frownies. If a thing is super compliant, we give 2 smileys. If it's compliant in just an ordinary sense, we give 1 smiley. If it's we have nothing to say about it under the heading of compliance, we just give a dash. If it's just in a straightforward way, not non-compliant, we give 1 frown, 1 frowny. And if it's super non-compliant, we give 2 frownies. So we have a scale of 5 levels: super compliant, compliant, nothing to say, non-compliant, and super non-compliant. And in some publications, this is represented differently, but the scale is the same. We can have a yes or a no to whether it's compliant or non-compliant. And a yes would mean a capital yes would mean super compliant, and a lowercase yes would mean just an ordinary level of compliance, and so on. You'll encounter both types of representation in the literature. So also on making these judgments, if you're not familiar with doing so, the sensitizing questions introduced by Lynette are very helpful. I think we can do a lot of work on developing them further, deriving from or more directly from clinical situations. But these are very, very helpful, and I commend them to you. Our first example now arises with Professor Augustus Brown, and he's an orthopedic surgeon. He's a formidable individual, as are some orthopedic surgeons, and is a very strong character, knows what he wants, and is determined to get it. And this is actually based on a real situation, even though it's simplified for the purpose of telling this story. So Professor Brown is, as I say, an orthopedic surgeon. He has a weekly public clinic in a big general hospital. He sees a lot of different types of patients. He will see new patients, patients that are being followed up from previous treatments. He will see new injuries, and you will see elective patients that are coming maybe after a long wait to have some problem dealt with. What's particularly interesting about Professor Brown's clinic, when a patient arrives at the clinic, they're greeted by the nurse. The nurse asks them if they have a current X-ray or a DVD from their most recent radiological examination of the part that is of interest for the clinic. If they haven't a film folder or a DVD from radiology, the nurse sends them directly to radiology to have the relevant part, to have radiographs or ultrasounds or whatever is required taken. Professor Brown won't see them without the film file folder or the DVD. Now, this is the director of radiology is very unhappy with this, as is the imaging medical physicist, and they both advised against this practice, which is contrary to justification. His response was dismissive, pointing out that the radiology service had considerable waiting times, whereas he ran an efficient, patient-friendly clinic, and he wasn't going to be distracted from that by issues like justification. The radiology department were obviously not happy, but they were also concerned that Professor Brown was a very influential figure in the hospital, and he might bypass the department entirely and take his referrals to another hospital or an external clinic, and thus they reluctantly accept the situation. So we have this rather difficult situation. In addition, Professor Brown reads the images himself, even if there's a report available, because reports are often delayed. So he generally just reads them himself. He's proud of the efficient patient-centered service that he organizes. So how do we make judgments on this situation? Well, using the kind of table we had earlier, we have the values across the top row, going from dignity and autonomy across through justice and solidarity, prudence, and so on to transparency. And under this heading, they do very, very badly on dignity and autonomy. The dignity and autonomy of the patient doesn't even enter into the decision whether they'll be imaging. The patient is greeted by the nurse, who will send them to imaging if they haven't a file. And they're not consulted, good, bad, or indifferent, and they won't get to see Professor Brown if they don't comply with that. Under beneficence and non-beneficence, we also get two frownies, because there's here a possible or potential harm with no corresponding benefit in many, many cases. Many people will have already had an examination and just don't have the file. Many people will also not need an examination for various reasons, but this is his approach to practice, and there is a certain efficiency in it for his own clinic. Under justice and solidarity, this is a poor use of resources, of scarce resources and difficult resources to source, and may deprive people who need a radiology examination of the examination. So we again give two frownies under this heading. Under prudence and precaution, there's an almost complete lack of prudential thinking here, because Professor Brown dismisses the possibility of cancer induction and so on at low doses of radiation. He says this is largely speculative, and he's not concerned about it. And finally, under honesty, transparency, and accountability, there's also two frownies because of the overall way the system is being managed and communication with the patient. You get two smileys. The first one under justice and solidarity, the two smileys are really awarded related to his wish and energy in pursuing an efficient clinic that will serve the patients well in a timely way and is very focused on them as long as they want the type of service Professor Brown is offering. Now, as I mentioned, the sensitizing questions can be quite valuable in trying to identify how you would reach those scores, and they're quite interesting to work your way down through them, but we don't have time to do it now. And I wouldn't I would almost be inclined to try and do it intuitively in the first instance, and you probably won't succeed always. If you don't succeed, I would go and use the sensitizing questions to give yourself a start, and that will almost always help. Our second example is from a Miss Julie Magenta, and Julie is aged 40. She attends her local hospital for an elective CT examination, an abdominal CT scan. She has a sense of urgency about wanting the CT scan because she's going on a planned holiday and she wants the scan out of the way before she goes. She was asked on arrival, she was asked at reception if she was pregnant. She replies, possibly with the holiday in mind, emphatically no, that she's not pregnant. She states on being questioned, that her periods are irregular, but she is quite sure she's not pregnant. The hospital decides to proceed with the scan due to the firm no and the sense of urgency that Julie Magenta has. Now, this interview with Julie when she arrived was conducted in a reception booth at the front of the waiting room. And this is a common arrangement in hospital outpatient clinics or in radiology departments. And in these booths, you can hear fairly well from one booth to the next. And often the receptionists in these areas, possibly because they often deal with patients who are elderly and deaf, but they speak very loud and they say, "Are you pregnant, Miss Magenta?" And Miss Magenta doesn't like her affairs being broadcast to the entire waiting room or to the adjacent booth. So she was actually having ongoing IVF treatment at the time of this interview at the reception area, and she thought maybe she should mention it, but the lack of privacy, because of the lack of privacy, she resisted saying anything and didn't reveal it. She subsequently, about a week or two later, she visits her obstetrician, and the obstetrician who was responsible for the IVF treatment, he indicates to her that she's probably pregnant, and she's absolutely delighted. She's over the moon with this, and I think thought all her birthdays had come at the same time. But later, a friend she was talking to about this in her neighborhood, the friend explained that the CT scan could have damaged the embryo or fetus if it was present at the time that the scan was performed. She's horrified and shocked at this. She's deeply distressed, and she decides, she thinks about it a lot. She decides she'll ring the hospital to find if the fetus could have been damaged by the CT scan. She's invited to come and meet the radiologist who was responsible for approving the CT scan, a Dr. Beaver. And Dr. Beaver indicated, he was very defensive, but he indicated very promptly that she shouldn't be concerned and needn't worry about it. And he says, even if the embryo had been damaged, it's likely that it wouldn't implant and would be lost, thereby ensuring no prospect of a harmed child. Miss Magenta was so distressed on hearing this because she hadn't revealed yet that she was receiving IVF and that conceiving was a problem for her. But she was so distressed on hearing this that she left before the interview was finished. So we here obviously have a situation that was very distressing for the lady involved, and the table at the bottom looks at how that would rate in an ethical evaluation. And again, looking at under each of the values across the top, and on under dignity and autonomy, we again, in this case, I think these two cases are fairly extreme, but I think they're selected for the reason that it's very easy to see what the outcome is. That again, the dignity and autonomy of Miss Magenta isn't well respected here, and part of the issue here is just the arrangements for interviewing people at reception, that they don't respect privacy. But they also get one smiley, and in this case, the smiley is given for the fact that they do ask the pregnancy question, because it would be omitted in many places. Under beneficence and non-maleficence, we have, again, a possible or a probable harm without a corresponding benefit. under justice and solidarity, and the way I scored this, I felt there was nothing in justice and solidarity that isn't already dealt with under the other headings. So I would score that we have nothing to say. Under prudence and precaution, again, there's a serious lack of prudential thinking. Prudential thinking applies when you've got a situation that can have a very serious outcome, but you don't have full information. And in that type of situation, you need to act cautiously, to act in a precautionary way often. And in this situation, I would say there was a serious lack of prudence and precaution. And there was a definite lack of inclusiveness and empathy in the way the overall process was addressed with this patient. And finally, one smiley was given in this situation. So that again, I think is one way of scoring it. Others might score it slightly differently. Again, the sensitizing questions are there, and the ones I associated with that are on inclusiveness and empathy. And again, you'll find them helpful if you find it difficult to do the scoring. So in conclusion, to begin to wrap up, we've looked at a method of scoring compliance and non-compliance with ethics values. The method facilitates transparency with ethics. We've only looked at 2 examples out of 11 in ICRP 157. They're not a guide to best practice, these examples. They're, in fact, the contrary. They tell you how to do bad practice. But they will allow a skill to be developed in using ethics, and they should allow ethics to become part of the lens with which we view practice. And they should add to how we conduct our business. There are lots of other scenarios in ICRP 157. Mary Coffey will speak about some of the radiotherapy shortly. Compliance and non-compliance scores in the tables are not unique correct answers. However, they're a starting point for discussion. You may also find that the scenarios provide a useful starting point to help generate new examples from your own experience and new sensitizing questions derived from clinical situations, because I think we need these. We need more questions that are more sensitizing questions, but that are closer to the clinical situation. This may sound like a lot of work, but it's essential to enable us to welcome ethics into our world, and to ensure that our standing is that of morally sound professionals, something I'm sure we all aspire to. So thank you very much for your attention, and that's it.
Thank you very much, Jim. As you just said, Mary will take the lead now and talk about radiation therapy, other example of the same method. So Mary, you have the floor.
Thank you very much, François. And I will add to what Jim said, but from the perspective of radiotherapy. And again, using really the same idea as Jim for the diagnostic. Now, interestingly, most of mine are real, and even though some of them are a bit extreme, they actually did happen. And I think they make for an interesting discussion. As Jim said, they're definitely not examples of good practice, but they do generate discussion. And I do think it's worth actually just stating that we also need to perhaps consider, well, what is radiation protection in radiotherapy? Because I think it is quite different to, sorry, this seems to have sat into the middle here. I think it is, wait now, I apologize, something has happened with my machine. Do you have a bar across in the middle? Because I have on mine. Okay, I'll move it out of the way. In radiotherapy, it's quite different to diagnostic because we are delivering a very high dose to the tumor with minimum dose to nearby normal tissues and sensitive organs. And I think that makes it intrinsically different. It's also quite difficult because the legislation looks at the sort of blanket term of radiology covering all activities. And I think that makes discussion on radiotherapy more difficult. But I tried with this case studies to look at this differentiation and looking at the principles of justification and optimization, specifically in a radiotherapy context, and considering all the ethical aspects which can be varied depending on the personnel involved. And what I did with the case studies was to try to follow the clinical pathway from diagnosis to follow-up, because I think there are different ethical issues in each scenario. So I started with Anna Fortuna. Now, this was a more older person, very thin, and very nervous. And she had had a melanoma on her ankle that had actually been resected 3 times. And this third resection resulted in an opened wound that wouldn't heal. Now, again, as sometimes happens in radiotherapy, the surgeon felt he couldn't do anything more for Anna, that he couldn't go in again and re-excise. So he decided to send her for radiotherapy. Now, you have to ask yourself, well, what was the evidence basis of that decision in the first place? Was it simply, I don't know what else I can do? But then you also have the issue of a radiation oncologist who accepted this patient for treatment. And that was also a very different type of discussion, because there is very little scientific evidence that radiotherapy is particularly effective in the case of melanoma, and particularly on an open wound on an ankle where you have very little tissue. There was a further problem with the patient, because when she was referred, the RTTs, the radiation therapists, were very nice, very kind, explained everything, and told her about drinking water to flush out toxins. But at no point during any of the discussion did anybody discuss with her skincare, which in this case is absolutely the core thing to look at. Now, she was a very nervous patient. She didn't want to accept the fact that there was nothing anybody could do for her, that she probably was facing a terminal phase in her life. So there were a lot of conflicting factors. So if you look then at the ethical evaluation, to some extent there was compliance with dignity and autonomy, because they were all trying to do something for the patient who really wanted some level of intervention. But there was also non-compliance, because they were definitely not following any evidence base in this case. There was also non-compliance with beneficence or non-maleficence, because it was certainly going to do her a lot more harm than good. And again, there was a problem, say, with transparency and accountability and honesty, because they didn't want to actually address the situation, that there wasn't anything they could do for this particular patient. They did try to be inclusive and empathic, because they did try to concur with her wish to have some type of treatment. But also it wasn't really empathic, because the level of side effects that she would have would be particularly difficult to deal with. And again, you can look at some of your sensitizing questions here and look at value and respect. And I think they did absolutely look at the value and respect and gave her that level of honesty and empathy. But I'm not sure that it really was the right thing to do, because where they did discuss the role of the patient wishes, and they did take that into consideration, the benefit was not consistent with the patient's goals of care. So it is an interesting one, and I think something that often occurs in radiotherapy, where a decision at the very beginning may not be right, and further down the line, other health professionals aren't in a position to query that first decision. The second option is another interesting challenge in radiotherapy, and it's where new technology is introduced. And when new technology is introduced into radiotherapy, everybody wants to use it. And sometimes it gets high publicity, and patients think it is better maybe than the original treatments that were offered. So this was a child, Emma, and she had quite a diffuse brain glioma. Now that's associated with a very poor prognosis, and there is very little effective treatment in most cases. So you are looking maybe at symptom control and possibly prolongation of life. In this instance, they were a family that didn't have very much money. They weren't financially well off, and they had very limited health insurance. Was an American example where health insurance would be very important. They had a local department near them that had high energy units, and treatment could start immediately and would be effective in this particular case. However, the oncologist felt obliged to discuss other options, and there was a proton unit some way away. So he thought he ought to discuss the option or the benefits of protons, because they are beneficial in treating children because they reduce the dose to the normal tissue. But it did offer a real ethical challenge to parents, because you always want to do the absolute best you can for your child. So you're left with a quandary. If I don't opt for protons, am I putting my child at a disadvantage? So it put them in a very difficult position. And I think it's one of the ones that is very hard to manage. There was really a lot of compliance with beneficence and non-maleficence, because there was the desire to do the very best for the child that they could. But there is some level of non-compliance, because it may not have been direct harm, but it was harm to the family unit in a way by putting this option that they would need to travel and it would become very expensive. There was a level of transparency and accountability and honesty, because obviously the oncologist was giving the best options that he could and was open to discussing this with the parents. And it was inclusive and empathic, because he was also looking to discuss with them what options were available and how they could best help their child. So yes, we look at the duty to promote or do good and to avoid harm, looking at balancing risks and benefits. And I think in that case, we have to look at, well, does the procedure provide a medical benefit? And no, in this case, it probably wouldn't. You can look at, is there a conflict between what the medical team thinks is the best course of action and what the patient would like? And again, as I say, when you're dealing with parents of children, it's extremely sensitive and very difficult to bring about that benefit. So I think it's one that does throw up many, many challenges. Another one that you do see a lot, and I have had direct experience of it, is when you have a new technology or a new technique and everybody wants to use it or to implement it. And this was Jane, who was a very frail lady, a 70-year-old with a laryngeal tumor, and she was a very thin lady with a very thin neck. And she was unfit for surgery due to her condition. So she was referred again for radiotherapy. Now, radiotherapy is very relevant in the management of larynx tumors, and you have very good results. So a simple technique would have been very, very beneficial here. But the department had been upgraded with 2 new linear accelerators, and they came with multi-leaf collimation. So that allows you to move leaves in and out and get a very tailored treatment approach. Now, the only problem in this particular department is resources had been limited. So although they bought the 2 brand new linears, they didn't have any accessory equipment. So they had no immobilization, and they had very limited training, and they actually had no experience with the new equipment. So where a very simple parallel opposed field would have been absolutely perfect, because they also had the potential for new planning. They produced a very complex plan with 5 fields that necessitated rotating back and forth around the patient. And in the absence of immobilization, was absolutely impossible to implement. So there wasn't really any compliance with dignity and autonomy, because this wouldn't be possible with the lady. They were definitely going to do more harm than good. And there was also a lack of transparency or accountability in trying to do something so complex in such a limited technical environment. And the lady was elderly and frail, so maybe it wouldn't have been that easy to be completely inclusive in terms of a technical discussion on a new technique, but I'm not sure that it demonstrated any attempt at that. And again, you can look at your sensitizing questions and the obligation to answer for decisions and actions to those who are affected and to accept the consequences, which could have been quite severe and quite unpleasant in this particular lady's case. And honesty, and it would be, have we discussed the additional information that would help the patient in their personal care and life decisions? And probably not, because the treatment was going to be longer, unpleasant, and the side effects would have been more severe, and it would have been unlikely to be as beneficial as something more straightforward. And then one which I think from the radiation therapist perspective is common. It's a 50-year-old man with early stage prostate cancer and an excellent prognosis. So he was referred again for curative treatment, which was very high dose, intensity modulated. So in that case where you've got a very focused treatment volume and you definitely want to avoid irradiation of the surrounding normal tissue, it's really important that the position that the patient is simulated in is replicated throughout the treatment. So in this particular case, in the first treatment patient set up, his trousers and underwear were pulled down to the level of his upper thighs. And again, this was very kind on the part of the therapists. They wanted to make him comfortable. They wanted to minimize his embarrassment by not removing all of his lower clothes. But it is absolutely impossible to replicate a setup like this. You don't have any idea where the trousers and underwear were. You're changing the position of your thighs. That's altering the pelvic position. So you are actually potentially doing a lot of harm. And again, you can look at compliance with dignity. They were looking to try to make this as dignified a procedure as they could, to mind the patient and to cause less embarrassment. But they were likely to do more harm than good, without any doubt. They weren't being totally honest, and I'm not sure honesty is the right word here. There is a lack of understanding sometimes on the part of therapists where their education may not be sufficient. They may not have understood the potential difficulty with this kind of a case. So it might have been difficult for them to explain why they needed the patient to be in this particular position. So it is difficult to state that. My slides, I'm afraid, are hopping about a bit, but maybe I'm pressing the wrong buttons. But I think this is an absolute case of making informed and carefully considered choices without the full knowledge of the scope and consequences of the actions, both on the part of the therapist and then on the part of the patient, because they couldn't get the correct information. And it's a clear example of not having enough knowledge about the uncertainty of the procedure and not considering the unintended consequences of the choices that have been made. And the last one then is, again, the fear of accepting that you've made a mistake, because nobody likes to accept that they made a mistake. It's not what we're about in trying to help patients. And this was a physicist who was appointed to a radiotherapy clinic, and they were doing high-dose brachytherapy, but she had no experience at all in this particular procedure. So a colleague was out sick and she was asked to plan the treatment. She did it quite reluctantly and the patient was treated. But a couple of days later, she realized she'd made a basic mistake, so the patient had been mistreated. Now, she was afraid of what her colleagues might think. She was new in the department and she decided that maybe it wasn't significant and she didn't need to report it. And unfortunately, it happens in these kind of cases quite often. So really, it's about upholding what is right, equitable, and fair. And this wasn't upholding right because you weren't able to repair the harm that might have been done. So I think you have to look at, were the resources limited? Were there sufficient rules? Were there sufficient staff? Did you follow what would have been the procedures? And it's a common enough scenario and one that we really need to think carefully about. So I think that ethics in radiation protection is very complex. You're dealing with patients at the most vulnerable time in their lives. You want to do the best you can, and sometimes it's not easy to accept that there are things you can't do, and also if you're doing something wrong. There's an education issue. If you actually don't understand what happens when you irradiate a patient, then by trying to be good to them, you can do more harm. There are 10 scenarios altogether, and I have tried to address probably one from each stage in the patient pathway. And I thank you for your attention.
Thank you very much, Mary. Now we arrive at the last presentation, Kimberly Applegate, who will talk about education and training. Kimberly, you have the floor.
Yes, thank you very much. I'm really pleased to be here today and share with you. So I want to again say, I want to appreciate Marie-Claire Canton, who was a member of Committee 3 since 2017, who sadly passed away last year. She was really the impetus for this publication and our work. I can't thank her enough. She was also part of our writing group for this final section on education and training and ethics, also with Mary Coffey, Bernard Leguin, and Maria Perez, who were also on the task group. So I will be brief and only highlight in this section the elements of the key messages that are the basis for the discussion in this section. And the outline is limited to 3 sections, 3 subsections, which is education and training of each of the relevant stakeholders. And so that's summarized with a couple of key messages with some background and introduction and links to some really important references. And then education for the engagement and empowerment of patients, families, and caregivers. And then education involving some of the less direct stakeholders of that don't necessarily work directly with patients and families. And then the next section, 8.2, is elements of ethical education and training in radiological protection and medicine with a couple of key messages, which we'll discuss in a minute. And then at the end, there are two important tables. François, at the introduction, talked about the taxonomy of learning, so I'm not going to go through it, but it has had a couple of revisions over the years. It's used in a number of different medical specialties now that has very explicit definitions for how we use knowledge, skills, competencies with attitudes and behaviors, and that's applied in Table 8.2. And then a few brief conclusions in section 8.3. So let's talk about some of these key messages, which are sprinkled throughout the document. The first in the section 8 is key message 26, which is everyone in all of the stakeholders is responsible. So it's a shared responsibility to assure that there is a strong radiological protection and that there are ethical values in healthcare. So each target group needs to be empowered and educated to ensure that patients are imaged and treated correctly. And that means that there are educational patient brochures that are available, if possible, on websites and that are given to patients and families when they come in or when they leave the health facility. And there are examples given in this document and in other ICRP documents from Committee 3. Key message 27 is, although it may be of value to integrate the ethics teaching into everyday practical education, it is also necessary that we provide specific practical teaching on ethics. It's that important. And then key message 28, radiological protection campaigns, has been mentioned by Chieko, have improved radiation health literacy for the consumer and provided transparent ethical values for all stakeholders. Now, we know that current medical practice is not uniform. There's a lot of variation, and that's been documented with numerous research publications. We also talk about it in some of our ICRP publications, including a recent one called Publication 154, and that's why it provides tiers of ways in which to practice and aspirational levels for which to keep moving in diagnostic imaging. So each radiological professional must have a foundation of these knowledge, skills, and competencies in their areas of expertise and in radiological protection, such as in using Publication 113 in the ICRP, in which to practice safe and effective in their area of expertise. And this must continue throughout their career from undergraduate level to the end of their career, and further that their employer should support these efforts. So every year or every 2 or 3 years. And that means with in-house or for them to attend meetings elsewhere. And we know there's wide variation in ethical education and training, yet that could be more standardized, and we provide some ways to do that. And ethical behavior and effective communication with the medical team and with patients are essential, such as in communicating the benefit and risk of different imaging and radiation therapy. So another example of this is in thinking about key message 26, where this section discusses authority-based decisions and ways to convert that to shared decision-making. And the ethical basis for this is using honesty and transparency in our value system. So all stakeholders require knowledge of ethics, practice locally. So it's sometimes has to be using current or local language, local values, and expectations. And ethics is an essential component of an effective and balanced radiological protection education and training that enables informed decision-making and helps achieve the greatest possible benefit at the lowest possible risk. That is key message 26. And we tailor education to each group. And I just put at the bottom of the slide a number of references taken from this section for further reading. So when we teach ethics, we can do this for an individual or for groups. And we gave examples of this before this publication came out by presenting this at a number of different meetings and getting feedback at that time. Now, key message 27 recommends dedicated but practical education, as I said before, at the undergraduate years and then lifelong throughout professional development. We never stop learning. And we know that societal and patient values are not static, right? There's evolution of the expectations that our patients put on us as professionals and society puts on us of what we are expected to do, such as disclosure of radiation risk and dose. And in our document, one of our key messages is that the doses should be kept in the medical record. And if patients or family ask what those are, we should be able to tell the patients and family what those doses and risks are. And then further, there will be ethical dilemmas throughout our work life. And we have to be able to process them. And of course, the methods as previously described, especially by Jim Malone, provides a balanced approach to arrive at a solution, and there's no correct answer. It will depend on many factors. And we provide a number of references and also programs. And I know one of the questions in the Q&A here is it possible to do this? And yeah, there are online programs if you don't have local materials that are already developed. So we provide those as well. So key message 28 talks about improving health literacy of patients and families. We know RP education and awareness programs, as mentioned by Chieko, have improved shared decision-making, consumer knowledge, and other stakeholder engagement. And facilities are responsible for talking about expectations for patients and then what patients should expect from the healthcare facility. All stakeholders are responsible, have responsibilities for ethical, safe, and appropriate use of radiation in medicine. So that was a very quick run through for that last chapter on education and training, but there's a lot of detail in there. So I wanted to give a conclusion on that, which is these guidelines, learning strategies, and references are meant to provide general information that have to be adopted and then locally adapted with the appropriate language and level for discussion. And the case scenarios for group discussion or individual review and reflection can be very helpful for helping with shared understanding and shared culture And then practical and longitudinal approach for integration of ethics and radiological protection into the medical curriculum can be a way to help with, again, shared culture and understanding, starting at the undergraduate level throughout the whole professional career. And then I did want to mention one other thing. I think Friedo mentioned that there are other ICRP works on ethics, and they include publication 153, which has some information on ethics regarding veterinary radiological protection. There are two other task groups. One is 126 on research ethics, and the other is a newer one, task group 130 on practical ethics. So with that, I want to stop sharing, and I think we have a little bit of time for questions and answers.
Thank you very much, Kimberly. Actually, yes, we have some time for question and answers. Actually, most of them have been answered already. So there are 16 questions that have been totally answered already, and there are still 2 that are open, and another one that is being answered right now. So I think we are doing quite a good job. So if you still have any question, the idea is that you write them down so everybody can benefit from them, and I can just encourage you to do it. And as I said at the beginning, the question and answers will also be made available to anybody after more than a week approximately. So I think we will answer the last ones. They are really detailed questions, so I think unless somebody from the task group would like to mention something. No, I look at the pictures of my colleagues. By the way, I thank my colleagues who worked hard during the who made the presentation and also worked hard during the presentation of the others to answer the questions. Well, in this case, if this is not the case, I think I will just thank you, the audience, to have taken the time to learn more about this publication. Maybe just reminds me a point of interest. If you go on our website to download the report, you will see that there is a document in which we describe how we answered the public consultation. So if you're interested in knowing a bit more about the impact that you can have when you answer for public consultation, you could have the summary of the responses that were given. If you look at it, you will see that we received quite a lot of questions, but we summarized actually in the document, we summarized the way we answered the remarks, and we are really grateful for the comments that were made, because didn't ask us to totally rewrite the report. That was good. But anyway, it really made the report better. It even actually changed the title, just to show you that the impact can also be significant. So thank you for those who contributed to the public consultation. Thank you for you who took part today. Thank you for my colleagues, and I wish a very good weekend to everybody. Okay, bye-bye.
Thank you, François.